myeloma is twice as common in the African American population. It's diagnosed younger in the African American population. It's actually also diagnosed younger in the Hispanic population. And that even though we tout myeloma as having this amazing survival advantage over the last decade, which is true, that advantage has not been seen in the African American population as much as we have seen in the Caucasian population. Similarly, not as much in the Hispanic population as well. So those are the key highlights. When people have access to those treatments, when there is that kind of equity, we actually see that outcomes, if not the same, are actually better for African American patients. So it highlights what I often call the 3 T's that are not accessed as well in the African American population: triplets, transplants, and trials. So those are some of the key things I like to say. And then when we talk about how we correct it, because I think there was a question about how are we going to do it, that could be a 20-minute answer, but it's not just a function of having more transplant, triplets, and trials. It's really engaging the community to change this course of myeloma. It really is an issue of trust and of long-term strategies that engage people in a way that resonates with them, to be able to trust their institution and their hospital or their physician or within their community. Number one, we know, even from studies that we've done in Africa and Ghana and other countries, that for reasons we don't really understand, the disease is twice as common from its earliest stage, from MGUS right through to myeloma. So it's not an environmental factor. It's not a later acquired phenomenon. So the baseline risk is significantly higher. But that secondly, experiencing myeloma, having it, has a lot to do with the whole experience that patients have with myeloma from diagnosis through treatment. And we know that, unfortunately, along the way, there's a significantly longer time to diagnosis in the African American population, of which has multiple reasons. Some of it is a lack of understanding, a lack of trust, a lack of education in the physician community. As part of one of my big projects that I'm working on later this year is to educate primary care doctors in primarily African American communities, so that when that man comes in with symptoms that I think of myeloma, they think of diabetes, diabetes, diabetes. I want them to think diabetes, diabetes, myeloma. I want it to be added to that differential diagnosis. So it's a multi-headed beast for the diagnosis, but also, as I mentioned before, access and so on all the way through. So it's a complex problem. We do know that certain cytogenetic features are more common in African Americans, namely what's called the translocation 1114, which with the right treatment actually can have a better outcome. So it tells us that there is a goal line that we can reach that can actually give superior outcomes, and yet we're now in inferior outcomes.